We have one final talk before the workshop that will start at 11 today. And it's BenVan Hout, Health Economics and Decision Science Department from the University of Sheffield. You are going to talk about the cost and benefits in new treatments for elderly, the old word for old people. How can we estimate the value? Welcome. Yeah. First of all, I always love to see if, although I know you're focused on your talk, was it something that struck you when you heard the former speaker?
Well, yeah, I like the fact that for the first time I saw somebody say that we get into trouble because of the fact that we don't have all the people that are going to do all this care for the elderly. Because one of the things that struck me when they've said, well, like the article is, what are we going to do? We're going to increase the, let's say, the retirement age. But my feeling is that, if you increase the retirement age, the only thing that you can do is make retired people into unemployed people. And it seems to me, to some extent, that, is what these retired people or the people after 65 should be doing is probably become nurses. And I was thinking that was quite striking me as, yeah, this is something to think about. Because it's not only the fact, it's not only money, it is also finding the people to do all this care. And I thought that was quite a nice thing to see, because I missed that in yesterday and also up till now.
Please tell us about your learnings.
Yeah, I'm a health economist, and I should know something about value. Maybe just get it out of the way. There's this joke about health economists that says, like, you ask a statistician, a mathematician, and a health economist how much is 1 + 1. The mathematician will tell you 2, the statistician will tell you probably 2, and the health economist will tell you what do you want it to be. Like this is, I'm first going to give you a little bit of observations. I have 30 slides for 20 minutes, so I'm highly likely to get a yellow card and definitely a red card. So here's the total cost of healthcare in a study from the Netherlands. What you see over here, the green one, or let's say the blue one is the smoking, the red one is the obese cohort, and the green one is the healthy cohort, just showing you that, of course, like healthy people are a lot more expensive than obese and, smoking people. The next slide shows a league table in terms of diseases. Like in terms of mortality, cardiovascular diseases was at that moment still number 1. It is now cancers or neoplasms. In terms of mortality, mental disorders is number 11. But do realize that in terms of direct cost of healthcare, the mental disorders, schizophrenia, dementia, and all these kind of diseases are number 1. In terms of work absence, which is also important, it's the low back pain that is number 1, the locomotor diseases, and also in terms of disability, like the locomotor diseases are number 1, just to give you a little bit of perspective about this. Another thing that is always a nice aha erlebnis, what are the consequences of total eradications? And I just want you to concentrate on those figures here. Like if we wouldn't have any MIs or ischemic heart disease anymore, a woman of 55 years of age would become 28, would have a life expectancy of 28 years. The increase in life expectancy because of not having any cardiovascular disease or ischemic heart disease anymore is 1.34, and the cost of healthcare will increase with about 7,000 euros. So indeed, the more effective we are, the more cost we will get. We're going to talk also this afternoon a little bit about economic evaluation and what do we do? Whenever there is a new therapy, we count costs. We look at the medical costs, which are the direct costs and the indirect costs. The indirect medical cost is a little bit of a thing that is open to discussion. It is the costs that are related to the fact that we keep people alive, and due to the fact that we keep people alive, they will incur costs. Do we take those into account or do we not take those into account? Within the Netherlands and within most guidelines will say, no, we are not going to take those into account. And this is something that is still quite open to discussion. Then there is the non-medical cost, the direct medical, non-medical cost, are costs associated with, for example, your partner helping you. But there's also the indirect non-medical costs, and what we mean with that are the production losses due to the fact that you don't work anymore. And there is also a lot of discussion whether they should be included or not. In the UK, they're only included if you work for the NHS. If you don't work for the NHS, we don't include them, but there is a little bit of a tendency to change that. In the Netherlands, you're allowed to take them into consideration, and here in Sweden, there's also something that, that you would like to take it into consideration. And then there is, these kind of things are very important. And I've just taken like a random article about the cost effectiveness in elderly individuals. And like the conclusion within this article is that the results remained cost-saving except for doubling the vaccination cost or including future medical costs of the survivors. So whether we take those things into account or whether we don't take those things into account is quite crucial in the decision whether you want to introduce this or not. And as such, like including the later cost is important, but also, of course, like including costs due to lost production may be important. And it is implicitly or explicitly, like it is discriminating the old people. It is now instead of elderly. So implicitly we are we are doing this. So, and the one thing that I would like, is like people who say, well, we should not include this. For these people, I have this slide. Like on the one hand, we have like, the Titanic going. Like there is this saving boat, yes? And now we have the following problem. 12 people want in, only 6 can go in, and of the 12 people, there's only 2 who can row. Yes, are you really going to say we're going to choose like without consideration of who is able to row or not? And my idea is that, by the way, that that you will. As a kind of an intermezzo, like there's within within society, like budget holders sometimes do say like the cheapest patient is a dead patient. If that ever happens to you, you say the cheapest budget holder is a dead budget holder. When thinking about the value of life and limb, one of the examples that I always enjoy is the Ford Pinto case. This is a case that has been in the United States. The Ford Pinto was a car that at a certain moment had a number of accidents. And some of those accidents, like the gas thing exploded. Yes, and then some people realized that internally there was a memo in the Ford company, that basically addressed this issue. And even worse, within this memo, within the Ford company, there was this calculation. Like the benefits, 180 burn deaths, 180 serious burn injuries, 2,100 burn vehicles. The unit costs $200,000 per death, $67,000 per injury, and $700 per vehicle. Total benefits, $49.5 million. They also calculated the costs, that was $137 million, and they came to the conclusion that we should leave like these, these gas on the same place as they were, because like the benefits were not outweighing the costs. And of course in the United States, then people go to the, to the judges and to the law, and they decided to sue the Ford company. And first the Ford company lost, but when the Ford company was also capable of showing where those $200,000 were coming from, and they were coming from the, the National Highway Traffic Safety Administration study, it appeared that everybody, of course, makes all kind of, like, considerations about life and death, and implicitly about whether we should make the roads broader or whether we shouldn't. And so, as such, like Ford at the end, came away with having those kind of calculations. And if we wouldn't, we would all be driving very boring, very safe cars. Another thing that, that strikes me about value, because I was asked to talk about value, and I'm going to read this one because I think it is almost stunning, and you have to be like, there is some American people here. After September 11, I confronted the challenge of placing a value of human life by calculating different amounts of compensation for each and every victim. The law required that I gave more money to the stockbroker, the bond trader, and the banker than to the waiter, the policeman, the fireman, and the soldier at the Pentagon. This is, again, another way of thinking about the value of life. But it does, again, tells us that we should, think about this. Implicitly, we do it in the UK, of course. Like here's a recent study about breast cancer. A drug called trastuzumab. And the results in the New England Journal of Medicine are as follows. What you see here is the overall survival, a p-value of 0.0001, which means that it is definitely true. So this drug is increasing survival. And what is it that the NHS has decided? This breast cancer drug is costing tens of thousands of pounds and more than other treatments, and it is unaffordable for the NHS. We're now not saying anymore that it is too expensive. We have a new trick, and we say the following. It will displace more health benefits which the NHS could achieve in other ways than it will offer patients with breast cancer. So this is the new way of saying we're not going to pay for this because it is too expensive, despite of the fact that it is, of course, like increasing survival. Now I want to address old versus young, and this is a blue slide because we're going to try to find out what you think about this. We're having a we're going to do this thing with the. So first I wanted to know, we're going to do an age-specific analysis. So first you have to tell us what's your age, and we think that this might be relevant. Have to see about it. Now imagine, in the meantime, imagine the following, yes? We have two patients, yes? One patient is 80 years of age, and he has, he has a kidney, or he has a kidney disease, and he is going to die. The other person is 40 years of age, he also has a kidney disease, and he's also going to die. We only have one kidney to give away to either one of those patients, yes? So they both have an in-Faust prognosis, and we can give them both 10 years. Yes? Who are we going to give the kidney to? Ooh! The next one, please. Now we have a man with 80 years old prognosis, again the same, in Faust, due to the fact that the 80-year-old man has a slightly less, let's say, immunosuppressive regimen that is very active, he has a better prognosis. So the 80-year-old man gets 5 years and the 40-year-old man gets 4 years. Well, okay, the next one, please. Now, the young man also has another disease that makes it only that he gets 1 year, yes? The 80-year-old man, 5 years, the young man, 1 year. Okay. There is a, there's definitely kind of a trade-off here that I'm quite enthusiastic about. Are we already getting... Okay, well, later on we get the data broken down by age. And the assumption that I will have, and that is based on this article from Jan van Busbach, is that, and it's probably because of the fact that we're all a little bit older here. Like if you do those kind of questions with younger people and older people, the younger people seem to have difficulties to give away the kidney to the younger person because it's politically a little bit incorrect. But the older people all give the kidney to the to the younger person. And to some extent, it acknowledges that like a life year in an older person is just worth slightly less than in a younger person. And we've played a lot around with this, and how do you call this? A 20-year-old versus a 80-year-old was a factor of 12.8. A 60-year-old versus an 80-year-old was a factor of 3.1. So there is differences in valuation, and you're allowed to take this into account. If you don't take it into account because you don't want to, because it is so politically incorrect, yes, then you are into difficulties, at least into my view. Good quality of life versus bad quality of life. How do we measure value is another question that we have. Like this is Alan Williams, who more or less introduces the concept of the QALY, which is a quality-adjusted life year gained, and in that case, life years are multiplied with a quality index, and that quality index is 1 for perfect health, and it is 0 for health stage equal to being death. And if you think that 2 years in this health state is worth 1 year in perfect health, then we use a value of 0.5. And this is the way that health economists play along in all kind of economic evaluations. Now, this is not a slide that I'm supposed that you want to read, but here are some of the instruments that we have. This is the generic instruments that can be used in basically every disease. And this is a book about health status and quality of life in older people. And here is a list of all the quality of life instruments that are available. What does this mean? Basically, it means that nobody really knows what quality of life is, and that you can measure it in many, many different ways, and everybody is right. And why is everybody correct? Because utility and quality of life is a metaphysical concept of impractical circularity. Utility is the quality in commodities that makes individuals want to buy them, and the fact that individuals want to buy them shows that they have utility. I know you could read this yourself, but I want you to be very aware. It is a circle. Nobody knows what quality of life is. Nobody knows what intelligence is. Intelligence is what an intelligence test measures, and quality of life is what a quality of life measurement measures. I'm a bit fanatic about those kind of things, sorry about that. The other thing that goes through healthcare is evidence. And evidence is something, you know, like if we don't have a p-value of 0.005, we're not going to do this. And let's be honest, who in the audience is married? That is a decision that has been taken without any randomized clinical trial with this one woman or with this one man, and it is taken under extreme uncertainty. So we do make decisions under uncertainty. Suddenly, when we're doing national policy, we want evidence, and we want evidence in an anal way, and nobody really knows what evidence. And then there is a little bit. What is it? This is a how do you call this? This is an article also in the New England Journal of Medicine about rivaroxaban in patients with ACS. And what we see over here is again a p-value of 0.005 or 0.008 in this case. And should this be reimbursed in the United States or not? And then it goes to the FDA. And here is the FDA advisory panel. So there are 4 people who said yes, 5 people who said no, and 1 person didn't vote or he abstained. Now the nice thing about this is that Mr. Foreman is a professor of statistics. Mr. Emerson is a professor of statistics. And Mr. Fleming is a professor of statistics. So is there really evidence? Do we know what evidence really is? Or are we truly all Bayesian statisticians? And of course we are all Bayesian statisticians, but I won't have time to get into that. Does that mean that I want to throw away all evidence? Of course not. Like here, this is something in a letter from the Minister of Health in the Netherlands about evidence. This is about like the introduction of the, how do you call this, moped and the age. You're allowed to drive a moped in the Netherlands if you're between 15 or 16 and 17. And here's the letters in Dutch saying that he wants to change it. And like here's the data on the basis of which it is happening. And what you don't see here is what you can't read probably, is that, how do you call this, the mortality rate is on the moped is, how do you call this, is highest for the people between 12 and 14. And as such, he comes to the conclusion, like basically we should increase the age from 16 to 17, not realizing that 16 is the first year you do it. And there is absolutely no, how do you call it? The other thing is, of course, like if you really want to take measures on the basis of that, you should take the elderly away from their mopeds. But that's that's another thing, and that's politically incorrect. The thing that is forgotten here is the following also. Like primates have the same dip in their mortality, in their puberty, especially male primates. And let me assure you, male primates do not drive mopeds. The other thing, like I don't know about like how to call it, and that's where you need evidence. When a minister of health tells you, for example, that how do you call this, that the Gini coefficient for how do you call this mortality decreases, and as such that is allows you to basically increase how do you call this, the age where you retire, is, can I say this, like respectful, utter nonsense. At least there's no evidence for that. Because like the age at which you retire is also like there's loads of people who are like building houses, and at the age of 62 their back hurts and they can't do something else. They are going to retire. And it may not be true for professors of health economics or for ministers of health, but it is definitely true for a lot of people that do other things. About choosing, do I have more? Am I red or am I yellow?
Red.
Red is about here.
Okay, red is about here. Well, this is like how do you call it, just to teach you a little bit about choosing. In the Netherlands, we have 4 big parties. There's the how do you call it, Conservative Party, which is the VVD, and they have like how do you call it, they have a high priority for right economic, yeah, like how do you call it, conservative economic policy, and they had like how do you call this, a preference for euthanasia. The Christian Democrats, slight, how do you call this, preference for right economic, but very much against euthanasia. D66 is another party, how do you call it, quite fanatically before euthanasia, and a little bit of a preference for left economics, and then PvdA, left economics, and a preference for euthanasia. What are we going to vote about euthanasia and right economic policy? Like it is very easy to, how do you call this, do the calculations. Number 3, left-wing economic policy plus 3 euthanasia is preferred above 2. 2 is preferred above 1. 1 is preferred above 4. And 3 is, how do you call this, 4 is preferred above 3. And as such, you can't decide. And this is one of the things that you, how do you call this, that we all will face. Nobody will ever be able to decide about this unless you have a human dictator. That's the last one. Thank you very much.
Okay, please, Richard.
Well, thank you very much. Up until that last discussion about the Dutch Parliament, I was going to say I admire your clarity. There are many, many dilemmas that you're very well aware of in terms of the whole issue about how you value drugs. You brought up the issue of Kadcyla, or however it's pronounced in the UK. You did not bring up, when you discussed Alan Williams, the famous quote, which will probably live in infamy, when he said, older people have had their valid innings. They've had their innings, I guess was the quote I remember him saying, which is in other words to say, go away, go die, please. That doesn't set well with the discussion we've been having here or with the data from Anders Ekholm in terms of extended life. That we're seeing healthy life that we're expecting to see from the elderly. So the question that I would ask is, how do the elderly, how do those of us who are aging, which includes everyone in this room, how do those of us who are aging take more control, as we discussed yesterday, over our health, over our ability to live healthy years? If the public sector uses discussions about healthy innings and the kinds of cost-effectiveness evaluation that you're describing, if health economics takes away the ability of the elderly to take advantage of new drugs that will extend their lives, that's the first question. And then the second question, which clearly goes with it, is Of course, you're not I don't mean you, but I'm thinking of NICE and the health economics and the quality approach. If you take away the public sector funding for these drugs, doesn't that really just mean that only poor people won't get them? As in the Herceptin model, the predecessor to Kadcyla, where middle-class women sold their houses in order to buy the drug, and lower-class women did not have that option.
Yeah, well, first of all, I don't think that like health economists immediately say that you shouldn't do it. Like we also, like if you want, how do you call this, equity to play an important role, you know, it is quite easy to prioritize the elderly, but be honest about it. Be honest about the fact that, how do you call this, that it is maybe slightly less efficient to, how do you call this, stimulate or like give elderly more life expectancy than younger. To some extent, I do not have any difficulty with that. It's the clarity about the decision, and I think that is quite crucial. I also think that, like within myself, you know, I am doing, I see money also a little bit of a social contract. To some extent, if I start to pay for the elderly now, yes, I hope that my children will pay for when I'm older. So, like how do you call this, it is a little bit the structure in which you want your society to be.
Well, most societies, that's what insurance is.
Yeah, but yeah, so most societies, but also NICE, how do you call this, is quite happy to take these considerations into account. So it isn't immediately that we want to shoot all the elderly or put them on a nice thing and let them go. It is just like how, because we need to realize that every money we spend on elderly, you know, has to come from somewhere. And I think that there is, like when you said at the beginning of this conference, that we're not going to talk about cost, I think it is crucial that you think about, like, where is the money coming from? And the one thing that you can't do is then maybe we should not do breast cancer screening. Yeah, you will have a few people with breast cancer that are relatively young, or we should not do cervical cancer screening, like ridiculously expensive, or at least the breast cancer screening is also, like, how do you call it, there's a lot of considerations about whether it is effective. And maybe we should be hard and say, well, we're not going to do it anymore. But we also, we have so much regrets if we stop doing things, especially when you can see that you've stopped doing things because of the fact that you are greedy or you don't want to spend the money on it. And then the other thing is, of course, saying, like, how do you call this, the taxes have to increase. But let's be honest, tax evasion is a very popular thing in every country. We don't like to pay taxes. So it is a little bit like, how do you call it, I do think, like, be honest and make hard choices. Making choices in healthcare is difficult. Having conferences and not saying how you're going to make the choices is not good.
Thank you.